Okay, so if we look at some examples of age-specific tests and measures, those are the Performance-Oriented Mobility Assessment, or the POMA. We have a Berg Balance Scale, BBS. We have the Functional Reach or Multidirectional Reach Test, MDRT. We have a Physical Performance and Mobility Exam. We have a Senior Fitness Test, and we have a Fullerton Advanced Balance Scale. Maybe good for Mike. So these are great tests that we could actually run on our patients, and I'm going to show you some videos that show these tests and how they're done. Now, examples of diagnostic specific tests. Okay, so remember all the other ones were age specific. These are diagnostic specific, used to examine functional limitations and underlying impairments in a specific patient population. So you have the motor assessment scale for stroke patients, remember, diagnosis. You have the Fugl-Meyer test, motor assessment in hemiplegia. Then you have a unified Parkinson's disease rating scale, that would be for Mike, and the Schwab classification Parkinson progression, Mike. So you have certain tests that you can do for diagnosis specific as well, or diagnosis specific. Now, exams at the strategy level, qualitative approach to measuring function activities, exams strategies used to perform functional tasks, strategies relate demands of tasks to capacity to perform it. Okay. Now, examination at the strategy level, qualitative measures, encompasses the evaluation of the movement pattern used to perform a task, as well as how the person organizes sensory and perceptual information necessary to perform a task in different environments. So at the strategy level, you would walking on a firm versus compliant surface, reaching for objects at different heights and distances, response to unexpected perturbation, like a little nudge test. So that would be at the strategy level. Okay. So these are just different tests. They all have their limitations. They all have their reasons. Now, how does a clinician or non-clinician choose which test to use? So this is the key, right? So you're like, oh my gosh, Patel, there's so many tests out there. Which one would you use? Well, there's couple factors. You can pick age. If they're young versus midlife to older, then you can say which ones. We always think safety first, right? So which ones would be appropriate for certain ones? We can do the age specific ones. We can do specific diagnosis. What's their level of function? We can do test-related factors, ability of test to accomplish purpose of examiner. Why are we doing the test? Even if we do the test, are we going to be able to use that information? There's psychometric properties, right? Cognitive properties, resource-related factors, skill and level of training needed, time available for the examiner. Can we even pull this off? Can we even do this test? And do we have the time? If a test takes an hour and they only have a 20-minute session, do we even have the time to do it? So again, examination at the strategy levels, there are limitations. This is methods for examining these strategies just being developed. Know very little about how compensatory strategies develop as a result of neurological impairments. So just because a patient can go from A to B, we're yet to determine all the compensations that can occur at the neurological level. It's very difficult. Brain injury is not easy. Anything neurological is not easy because everyone is so different. Now, limitations of functional tests and measures does not provide information as to why, and here's the key, as to why the patient is dependent in performing functional skills. Will not allow testing of hypothesis about cause of motor dysfunction. Limited to only measuring the degree of which a patient client can perform a task, and limited to measuring performance at one instant in time under a fairly limited set of circumstances. So functional tests and measures, they're great, but they have a lot of limitations. Okay. So limitations to strategy examination of function. Many methods for examining strategy use are only just now being developed. We know very little about how the compensatory strategies develop as a result of neurological impairments, and observational gait analysis is one example of a method used to define the movement strategies used during gait. So I kind of briefly touched on that here, but there's a little bit more detail. Now, examination at the impairment level. So it requires examination of impairments within individual sensory, motor, and cognitive systems contributing to motor control, as well as multi-system impairments of posture, balance, and gait. A lot of stuff going on. So when the motor system examination includes neuromuscular and musculo-MSK systems, examination of sensory and perceptual abilities, cognitive aspects of motor control must be examined because task-specific movements are performed within the context of motivation and intention. So it's getting pretty deep here. You're like, what's going on here? So in summary, a task-oriented approach to examination attempts to answer the following questions. To what degree can a client perform functional tasks, and what strategies does the client use to perform the task, and how and can he adapt strategies to changing task and environmental conditions? So if you can answer these two questions, then a task-oriented approach to examination would be appropriate. Task-oriented approach to examination attempts to answer what is the constellation of impairments that contains how the client performs the task, and can these impairments be changed through intervention? Can we even make a change? Is the patient-client performing optimally given the current set of impairments, or can therapy improve either the strategies being used to accomplish functional tasks or underlying impairments? Again, some of it is repetitive, but really you need to be able to answer these questions if you're going to use a task-oriented approach. Now, what's the difference between recovery versus compensation? Whether the emphasis is placed on recovery versus compensation varies from person to person, is often based on time, acute versus chronic stage of recovery, and depends on the nature of the impairment, permanent or temporary. Did they have a TIA or did they have a stroke? All right. So a lot of stuff going on here. The key is there's a lot of tests that we can do. There's a lot of theories out there, but we need some kind of framework to put it all together. And hopefully you have a systematic way of looking at these frameworks. But the key is there's a lot of environmental factors, personal factors that can play a role in a person's recovery. Not everyone's the same. Don't use the same cookie cutter recipe. So every Parkinson's patient doesn't get the same exercises. Every CP child does not get the same exercises. Everyone with a stroke does not get the same exercises because they all live in different things. There's different factors that will affect their recovery. So just keep that in mind.